Hello, my name is Angela Esposito, and I'm going to go over the surgery preoperative expectations, preoperative evaluation PowerPoint with you. This is actually a summation of an article called Preoperative Evaluation Before Non-Cardiac Surgery. It was put out by the Mayo Clinic. It's actually part of a series that they did. It's a very lengthy article. So I am doing a summation and pulling out the high points of this article. So to begin with, we're going to go over anesthesia, the different types of anesthesia that is used. General anesthesia is one of the ones that they use for the larger surgeries. They put the patient completely under. The patient is unconscious. They have to be intubated to protect their airway. The effects of general anesthesia include vasodilation, decreased heart rate, decreased stroke volume, respiratory impairment, reduced lung volume, and airway closure, therefore the intubation. Basically, the anesthesiologist, or typically the CRNA, is monitoring the vital signs, making sure the patient is breathing well, the blood pressure stays where it should be, giving them the medications that they need to keep them stable. The second type of anesthesia is neuraxial anesthesia, and these are your blocks: epidurals, spinal blocks, regional type blocks. For these blocks, the patient is usually conscious. The side effects of the neuraxial anesthesia include a sense of dyspnea, a reduction in cough strength, reduction in expiratory effort, and urinary retention, because we've put part of their body to sleep. A lot of times, if you're having a C-section, they will do a spinal or epidural on you so that you're still awake and you can hear what's going on. And when the baby is born, you can see the baby, but you can't move your legs. You can't feel what's going on when they cut into your abdomen. One of the risks of a spinal block is that if it is too high or it goes in the wrong direction, it can paralyze the accessory muscles and the diaphragm and can affect breathing. And in that case, it becomes an emergency situation. Before a patient goes into surgery, it is very important that they have a preoperative history and physical. The purpose of the history and physical is that it gathers information so that we can do a risk assessment and reduce the risk of the patient once they are under anesthesia. It also helps aid the anesthetic in anesthetic management. It helps the anesthesiologist determine, can this person receive general anesthesia, or are their lungs not healthy enough for that? Do we need to do a block of some sort so that we don't have to put them completely under anesthesia? Also, the history and physical allows the doctor to look at the severity and the stability of the patient's comorbidities and their chronic illnesses. Do they have COPD? Can we not put them under? So a preoperative history and physical is very important, and it needs to be, we need to have a recent one within 30 days in order to take a patient to surgery. The benefits of the preoperative history and physical, it includes the safety, ensures the safety of the perioperative care. It optimizes the resource usage. It improves the outcomes, and it increases patient satisfaction. We don't want to get a patient down to prepare them for surgery and all of a sudden find out that they can't be put to sleep and we can't do the surgery and we have to send them back to their room. That is a waste of resources. The patient gets upset, and it is not good for anyone involved. So there are some patients who need specific evaluations. So cardiac is one that they look closely at. Patients with known cardiac disease should be closely assessed. Some of them even need to have cardiology clearance before they go to surgery. And sometimes they don't need to see a cardiologist. They just need to have tests or labs before they go to their surgery. Maybe they need an EKG. Maybe they just need a BMP, something to make sure their potassium is okay. Sometimes just whatever the anesthesiologist feels is necessary. Some of the factors that throw up red flags for our anesthesiologist: has the patient had a heart attack or a stroke within the last year? Has the patient had a cardiac stent put in within the last 3 months? Is the patient on any kind of anticoagulant or antiplatelet medication? Are they on Eliquis? When's the last time they had their Eliquis? Are they on Coumadin? What's their PT-INR? All of these things are important for our anesthesiologist to know. Pulmonary is another important system to evaluate. Obviously, breathing is very important. Any surgery that takes place on your head, neck, upper abdomen, thoracic area, that makes the pulmonary risks higher. Patients should be assessed for any new or progressive pulmonary disorders. Did you just get diagnosed with obstructive sleep apnea? Are you just new to a CPAP? These are things we need to know. Diagnoses that need to flag a nurse or the anesthesiologist: does the patient have COPD? Do they have obstructive sleep apnea? Do they have asthma? Are they a smoker? Were they a smoker formerly? Do they have other hypoventilative syndromes? These are things that the nurse and the anesthesiologist should know. Another big thing to evaluate is VTE, the chance of a venous thromboembolism. Surgery puts any patient at high risk for a clot. All hospitalized patients are at risk for having a clot. Most of them are either on anticoagulation therapy, or they have all the mechanical sleeves on their legs that massage them to keep their blood flowing. Patients who are at high risk for clots include how much tissue injury is involved with the surgery, how much you're going to cut to perform the surgery, the location and the duration of the procedure. Where is the surgery being done, and how long are you going to be under the anesthesia? How long are you going to be laying still like that during the procedure? Immobilization. How long are you going to be not moving? How long are you going to be not moving after the procedure? And any pro-inflammatory states like cancer, that automatically raises your risk to get a clot after surgery. Preoperative testing. Most surgeries do not require a lot of preoperative testing. At our facility, all women under the age of 50 years old must receive a pregnancy test unless they have been surgically sterilized. All of them have to have a pregnancy test. Now, all diabetics must have blood sugars. If they're on the floor, we need to know what their last blood sugar was and the last time they received their insulin or their medication, their diabetic medication. Obviously, if a patient is on antiplatelet medication, if they're on Coumadin, we need to know their PT-INR. If they have just gotten a new diagnosis for irregular heart rhythm, we need an EKG. If they're in AFib, if they've had irregular beats, we need an EKG to see that. And there may be other things that the surgeon or the anesthesiologist want to see. They may want to know what their potassium level is. They may want to know what their hemoglobin and hematocrit are. So anything that the surgeon or the anesthesiologist deem necessary are things that we need to know. And also, patients who have total joints, they do have a long list of things that need to be looked at preoperatively. Risk assessment. Every patient needs to have a risk assessment done. They're done to address and modify any problems preoperatively to increase the success of the surgery. So you have to look at the urgency of the surgery. Is it an elective surgery? Can we put it off if things aren't good today? Is it urgent? Do we need to do it as soon as possible, but we could wait for a little bit? Or is it emergent? Is it something that has to be done right now and we can't wait? Surgery site specific risk. How much tissue is going to be disrupted? How much blood are we going to lose? Is there going to be fluid shifts in the patient that's going to cause them to be at higher risk? Patient specific risk. What are the patient's illnesses? What do they have that may put them at higher risk for this surgery? And the status of the comorbidities. The patient may be diabetic, but maybe that diabetes is under very good control, or maybe this patient's A1C is 12. So what is the status of their comorbidities? But the bottom line is ultimately, if the surgery is not an emergent surgery, you need to, if the risks outweigh the benefits, the surgery should be delayed or be canceled. If it's an elective surgery, and if it's urgent and can be postponed until corrections are made, you need to consider delaying or canceling if the risk outweigh the benefits. I hope this answers some questions for you.